a brief preview of the lecture video on the topic sonography of gestational trophoblastic disease, available on the website sonoshare.in on subscription. This is only a review. The main lecture is available on the website. Short snippets of the various parts of the lecture video will follow. Having gone through the preview, if you wish to listen to the main lecture video, go to sonoshare.in. So this lecture covers this disease as per trophoblastic tumor. In complete mole, it is markedly elevated. 50% of complete mole has a value of more than 1 lakh units. Less than 10% of partial moles have tissue, extensive hydropic change of the villi, excess trophoblastic proliferation, and in partial mole, the features are presence of ovum by 2 sperms. This is the cause in 20 to 25%, and the karyotype is 46XY or 46XX. In fetal tissue is characteristically absent. The feature is hydropic villi and trophoblastic hyperplasia, and prognosis is poor because 15 to 25% will have a malignant sequelae. Complete mole on ultrasound in the second trimester has got a very characteristic picture of an echogenic mass with multiple cystic spaces. Numerous cystic spaces filling the may or may not be flow seen in the mass. And if you do spectral Doppler, there will be a low resistance flow. The differential diagnosis for this appearance in first trimester is either failed, that is the characteristic of partial mole. And this appearance of the placenta is called the Swiss cheese pattern. Now here you see an example of partial mole. You see fetus posteriorly, anteriorly you see the placenta which is enlarged, and there are multiple cystic spaces mimicking a mole, but there is fetal tissue. So this is characteristic of partial mole, enlarged placenta with a Beckwith-Wiedemann syndrome. And when you have a doubt, we need to confirm by doing amniocentesis and doing a karyotype. Karyotype will be normal, whereas in partial mole it will be triploidy. So this is an example of placental mesenchymal dysplasia. You see the placenta increased in thickness, and you see the cystic spaces, and there is a fetus which was normal. Coexistent mole and fetus, and this also can have theca lutein cysts of the ovaries because of the elevated beta HCG. So coexistent mole and fetus in very early pregnancy. An example, you see follow-up for 6 months from the normalization of the HCG level. In case of partial mole, follow-up concluded once the HCG has returned to normal on 2 samples at least 4 weeks apart. So beyond that, there is no need to follow. Recurrence of gestational trophoblastic disease. Incidence of due to the AV shunts, and on spectral Doppler there is high velocity, low resistance flow, very classical of gestational trophoblastic neoplasia. Another case, you see the myometrial endometrial heterogeneous metastasis. It depends on the site of metastasis. Brain metastasis may present with headache, seizures and hemiplegia. Lung metastasis may present with dyspnea, cough and chest pain. For non-molar GTN, diagnosis persistent vaginal bleeding lasting more than 8 weeks after a pregnancy event, it should be suspected, and urine HCG tests should be done, and if it is elevated, then we must think of this condition. And also it should be considered when there is a miscarriage without a fetal part, and in that case material obtained is sent to pathology. Pregnant about 2% with uterine AVMs may require treatment for refractory vaginal bleeding, and the treatment may be by embolization. Uterine arteriovenous malformation after GTD, The arteriovenous shunting is part of the pathogenesis of GTD and results from uncontrolled proliferation of trophoblast and invasion of the myometrium. It may persist up to 10 to 15% of patients even after complete resolution of GTD. AVMs may complicate any type of GTD and may be